Wonderful talk. Şengül is ready on the podium, so we can give first her talk. All right. We can switch to Dr. Şengül. I
Sorry.
just want, it's
I
okay.
thought it was mine.
It's
Oh.
okay. It's okay. It doesn't matter.
Sorry.
Before you start, Şengül, I want to, because we heard the company talk, and I want to point out that sometimes colleagues tell me we don't need the wide field OCT because we already have very good OCT. What can they add to our practice? And I think that every time the technology goes toward, one way, then we adapt and we learn new things, because most of the time when we are able to see something new, then we learn new things and we are able to do new things. So it happens in the same way when the OCT started. At the first, we didn't know exactly what to do with it, but it was just because it was at the beginning. And the same happened when OCTA came in, and most of us were saying, I will keep doing fluorescein angiography. But now we are switching. And why are we switching? Because the technology is better and better and better, and we are adjusting our practice to the technology. So the same thing is happening with the wide field technology. And I have seen really art. These are pieces of art. I would like to hang pictures of this in my house somewhere. So from the company talks, now we switch to real-life experiences with the new technology. The first is Dr. Şengül Özdek presenting peripheral retinal imaging with OCT in pediatric retinal diseases. Thank you.
Thank you, Barbara. Now we have heard about fantastic machines which come into our life and which made our life even easier. I will just try to present my experience for the last couple of months, especially in pediatric patients. You know, it's always difficult for pediatric to image the pediatric retina, and also it's demanding for the technicians and the families. They're all doing their best to get the best images as we can, especially for the small children. And they need additional devices, especially for the babies. And image acquisition time has to be very short to get images. And we know that we have wide field and ultra wide field imaging technologies, and wide field is defined as over 60 degrees, like between 60 to 100 degrees. Ultra wide field is between 100, over 100 till 200 or more. It can be colored fundus pictures, OCT or OCTA. And the International Wide Field Imaging Study Group has defined these ranges, and they have defined the ultra-wide field, the border of the ultra-wide field from wide field according to the ampulla of the vortex veins. And we have a lot of contact wide field imaging devices for babies. This is not the content of this talk, but I want to share one new machine which will be on the market next year, which is expected to be in the market next year, which is ICAM OCT, and it's developed by Peter Campbell, and it's a contact one, spectral swept source OCT again, and it has 200 degrees of degree of field of view, and it takes the images less than 1 second. So it will be a very good addition for pediatric retinal imaging for sure. And we have also some non-contact devices, as we have seen in detail just in the previous talks, and they are amazing. You know, we were talking about like 3 millimeter or 6 millimeter images. Now we are talking about more than 20 millimeter images, like 26 millimeter, and depth is incredible, especially for the myopic eyes. So where do we use this ultra-wide field OCT? In pediatrics, we can use it in screening, monitoring, for the follow-up, for the diagnosis of the peripheral pathologies that we cannot see very well with the just colored pictures. I will show you some examples. This is a 14-year-old boy who had a premature birth history and didn't have any treatment before, and vision is quite good, 0.8 in the right eye, full in the left eye, but you can see a little bit of nasal ectopia of the macula in the right eye. And the periphery, in the periphery you can see there are a lot of vitreoretinal pathologic relation with some membranes and some peripheral retinal pathologies. And what I did for this case is I did a prophylactic encircling buckle in both eyes because I was very anxious to do laser beforehand. If I do the laser beforehand, it may cause contraction of those membranes and I may induce some retinal break formation. That's why I put prophylactic buckle first and then laser. But it was difficult to make people understand why I was so aggressive in such cases. But when we and this is the after laser, when we do this wide field OCT, ultra wide field OCT, peripheral retinal imaging with OCT, you see how much there is traction in the periphery. They're causing retinoschisis in the periphery in many places. And if you don't do anything, they will end up with retinal break-in at some point for sure. So they need an aggressive prophylaxis. So this make me understand and this make me explain to the families and to the colleagues also how it is important. And this is another case, again, with peripheral laser during the premature babyhood. And you can see, again, the peripheral vitreous changes, vitreoretinal tractions in the periphery. And this is another case with Stickler syndrome. Actually, he was a boy, and he came to me with retinal detachment in the right eye 10 years old earlier. And I did encircling buckle with a local sponge, and the other eye developed retinal detachment too. I did the similar buckling surgery, and it was going very well. But then he came with this pyogenic granuloma in the right eye, in the inferior temporal part where there was a sponge. It was silent for 10 years, but then it came with this. So we had to do an extraction of the buccal, but it caused recurrence of the retinal detachment in the superotemporal part, interesting, because it made the encircling buccal loose and it caused recurrence in the superotemporal part. And this was the appearance in the OCT, and we did a little bit of laser, not to be too posterior, but it progressed, and we can see the progression in the OCT. You can see the laser indentations in the OCT, and then we understand that it's progressing. So I put another buccal in the superotemporal part, and it controlled the condition very well. And this is another patient, 8 years old boy with congenital X-linked retinoschisis with bullous inner retinal layer schisis. The fellow eye had been already operated for bullous retinoschisis, but this eye, which is supposed to be good eye, you see in the temporal part we have inner retinal layer which causes some traction in the retina, and also we have, as you see here, we have an inner retinal defect in the periphery, which can be seen very nicely both in the infrared picture and also in the OCT scan. So those are much visible after this technology. And this is the fellow eye of the same case. We have done the inner layer retinectomy with vitrectomy for this eye. Now it looks quite well in the OCT. And we can also follow the retinoschisis causing retinal detachment in the periphery. This was an acquired one, actually, retinoschisis, but although it looks quite fine from with this view, but we can see that there is an associated retinal detachment just in the border of the retinoschisis, which was has already been lasered to prevent progression. But so we have to follow that retinal detachment area too. And in another acquired retinoschisis case, you can see again retinal detachment in the border of the retinoschisis. You may not realize it by the ophthalmoscopy, by just looking with your indirect ophthalmoscopy. So this is a Coats disease case. You can see the subretinal bands, subretinal fibrosis very well. And this is another Coats disease case. But the OCT angiography, wide field OCT angiography is amazing in these cases. You can see the telangiectasia and also associated ischemic areas, as well as the neovascularization in the subfoveal nodule. And this is another case. This is also very amazing because 5-year-old girl with incontinentia pigmenti, and the right eye is kind of amblyopic, 2 meters, counting finger. Left eye is the better eye. The central OCT, you can see a little bit of membrane causing some traction in the macular area. But in OCT, you see how much ischemic is the peripheral retina. Not only peripheral retina, but we also have some capillary non-perfusion, even posterior to in the posterior area too. This was the right eye, and we also did the angiography to the left eye, fluorescein. Of course, it's not fluorescein. And we can see it very well in a 5-year-old girl. Since the acquisition time is quite low, it's very easy to get it. And, you know, even fluorescein angiography is not so easy for such small children. And this was another case, a 19-year-old fever case with rhegmatogenous retinal detachment in the avascular retina, and we did just scleral buccal cryosurgery, and it went very well. We did it in both eyes, and this is the OCT of that case. You see how much vitreoretinal traction and membranes are still there in the periphery when you just check it, and you can see the peripheral avascular retina in the periphery with the OCT angiography. It's very helpful in these cases. And this was the fellow eye of this same case. He also had a localized retinal detachment in the fellow eye of the fever case, and we did this scleral buccal thing again, and it worked very well. This is the OCT angiography of the left eye. So we have some other fever cases, which was very helpful. This is a degenerative myopia eye. You can see how deep is the imaging depth is so long, so you can easily see the posterior pathologies, anterior pathologies all together. And you can see the whole picture. You see in the upper picture, we have only macula on. The peripheral retina is totally off, retinal detachment, and we have cystoid macular edema. You can see everything all together. And in the lower picture, you have the lamellar hole with partial PVD. And this is a retinoschisis and tractional retinal detachment caused by, again, vitreous traction. And we can also see the peripheral retinal degenerations very well, although we see it with our eyes. How you see here how retina is thin and disorganized in those areas. So it's easy to make people understand what's going on in their eyes by showing these pictures. And this was a 6-year-old pars planitis patient. You see the peripheral tractions in the inferior part causing tractions in the peripheral retina. And now you can understand it very well that it may have some problems in the peripheral retina in future. And this is the last case that I want to share with you. This is a bilateral retinal hemangioblastoma case. It's a very recent case. We have seen her very recently. And you see that there was vitreous hemorrhage in the right eye. associated with the nasal feeder vessels and nasal hemangioblastoma. And the left eye was doing well, but she has another hemangioblastoma in that eye. So there were also some small hemangioblastomas more. In the central, you don't see anything, but in the periphery, you can see, I mean, in the OCT, you can see the peripheral tractions and the tumor itself. And in angiography, it's so nicely, beautifully seen. There's peripheral ischemia, and the hemangioblastoma can be seen very well. So my take-home messages are these wide field and ultra-wide field OCT and OCTA are extremely important to understand the peripheral retinal pathologies in pediatric retinal diseases for both diagnosis, management, and follow-up. And new machines with shorter image acquisition time with larger field of view will make the future for sure. Thank you.
Şengül, wonderful presentation. So in the next